Okay, moving on. We're going to talk about head injuries. There's several different types: concussion, contusion, intracranial hemorrhage, epidural hematoma, and a subdural hematoma, and then just a fracture as well. Mild concussion, the word means violent shaking. It really is just a momentary interruption of brain function. It can lead to a loss of consciousness on impact. That's a really important question to ask if someone's had a head injury. Was there any loss of consciousness? That could just last seconds, may persist for several hours. Most often it's just seconds. Other symptoms: headache, drowsiness, confusion, dizziness, and sometimes some verbal disturbances as well. So this typically doesn't require much treatment. A contusion, a little more serious. This is bruising of the actual brain tissue. So most commonly it's found right at the site of impact. You can hit your head so hard that you have something called a contre-coup injury. So basically the contents of the brain, when you're hit, for example, in the front part of your skull, the force is so hard that the brain basically hits the object and then goes back into place and hits the occipital part of the skull, which causes an opposite line of impact. So you can have both a frontal and occipital, or frontal and temporal lobes, whichever. So just beware of the contre-coup. Couple pictures of just a contusion, what that looks like. There's some types of force. I'm not going to ask any specific questions about this, but if you are working in an emergency department, you'll hear these types of terms: acceleration injury, deceleration injury, etc. Acceleration is caused by an external force contacting the head, so suddenly placing the head in motion. Deceleration is when the moving head is suddenly stopped or hits a stationary object. As far as fractures go, linear skull fracture is by far the most common, counts for about 80%, and it's a nice fracture because it's just a real simple, clean break, and it's pretty straight, hence the word linear. Still can cause some intracranial pressure, etc., but one of the better ones. Probably the worst one would be a depressed skull fracture, and that's when the bone actually is pressed inward into the brain tissue. Okay, and basilar skull fracture, that's not a great one to have as well. It can be fairly complicated. It's involved with the base of the skull. It can also involve the sinuses and the temporal bone, which indicates or can cause middle ear damage. If the dura is disrupted with a basilar skull fracture, which it often is, cerebral spinal fluid can leak through that tear. So this can be noted clinically by having kind of a runny nose, so rhinorrhea, or you can have it out your ear, so that's otorrhea. So blood may also be noted, or at least bruising over the mastoid process. That's called the battle sign. And then you can have bilateral periorbital ecchymosis or bruising. You know, what the heck, we don't want to call it a bruise. Not one we can be fancy. We like to call it ecchymosis. Anyway, if you have bilateral black eyes, that's called raccoon's eyes. So the two big signs for basilar skull fractures are battle sign and raccoon eyes. There's a couple pictures of those two signs. With CSF, if you do have rhinorrhea or otorrhea, taking that drainage and testing it for glucose would be a good way to check for CSF. So next thing we want to talk about is an epidural hematoma. This is a big, bad arterial bleed, and it occurs between the space of the dura and the inner table of the skull. It's often caused by the temporal bone being fractured. Now, the temporal bone is really significant because it holds the meningeal artery. So one of the most common problems or causes of an epidural hematoma then. And so the big thing with this one is that it's fast and furious. So you may go assess a patient and they're pretty lucid, and then minutes later their level of consciousness declines really rapidly from drowsiness even to a coma. So a hallmark sign for an epidural hematoma then is rapid neurological decline. So this one it's obviously a medical emergency, and they need to get into surgery as soon as possible, and that arterial bleed needs to be controlled. So signs and symptoms of hematoma would be a severe headache, vomiting. Check the pupils out. Typically you have a fixed dilated pupil on the same side of the hematoma. You might have hemiparesis or hemiplegia, so a little paralysis on an affected side, seizures, and again, early intervention is imperative. So a couple slides there, one showing a CAT scan, and you can see how the ventricles of the brain are shifted way over. The next type of hematoma would be a subdural. Now you would think that an arterial bleed would be probably the most deadly. It's not. It actually is the subdural, and the reason why is that a subdural hematoma is a venous bleed, and so that can happen really slowly. That happens between the dura and above the arachnoid. So really helpful if you just go back to your basic anatomy and just look at the anatomy of the brain, so you know these different spaces, and of course the dura is that covering that sits really very tough. Anyway, the subdural hematoma results from a tearing of the bridging of the veins within the cerebral hemispheres. So this bleeding occurs really slowly, and it's kind of sneaky. And so there's different levels of hematomas, but it is possible that you fall, hit your head, you're fine, and then even a month later you start getting confused and you have a subdural hematoma, have no recollection of even having any trauma, and older people a lot of times don't get the help that they need, end up dying because of this slow venous bleed then. So if you had to choose between an epidural and a subdural hematoma, even though an epidural is arterial and fast and furious, you want to go with that one. And this is the case typically, you know, in our lives and clinically. If there's big symptoms, that gets our attention and you get treatment, you know, quickly, as opposed to real subtle symptoms. Sometimes those get ignored and they can be really quite deadly. So there's the three categories then of the hematoma. You have acute, subacute, and chronic. And the acute one is actually one that you probably are luckiest to get, because it presents itself within 48 hours, so just 2 days. Subacute, anywhere between 2 days, 48 hours, and 2 weeks. And then a chronic can be 2 weeks to several months. So again, they do have the highest mortality rate. A couple slides just showing subdural hematomas. And then you have an intracerebral hemorrhage. This is caused by tearing of the small arteries and veins. You can have single or multiple contusions with this one. Most often, if someone has an intracerebral hemorrhage, it's frontal or temporal. So a subarachnoid hemorrhage, this one is typically caused by an aneurysm. So it's between the arachnoid and the brain, where the cerebral spinal fluid circulates around that brain tissue. The blood vessels are located along the surface of the brain as well. And if you can have a subarachnoid hemorrhage from trauma as well. More commonly, it's an aneurysm, but they will combine with the CSF along that. So that's why it's below the arachnoid. So subarachnoid bleed. Blood vessels are also along the surface of the brain too. So signs and symptoms of the subarachnoid hemorrhage are just the classic thunderclap headache. So patient will say, "Oh, this is just the worst headache I've ever had in my life." And you would ask things like, do you have migraines? And if they do, is it anything like that? And most often people will say, this is unlike anything. So most often the headache is located more in the occipital area. Patients can have vomiting, seizures, neck stiffness. That's usually about 6 hours after onset. They're real sensitive to light, so they have photophobia. They may even have an isolated dilation of a pupil. So you can see these symptoms actually can fit other things. So history is really important to get as well, not to mention diagnostic exams like an MRI or an MRA. So the MRA with angiography is more specific to looking at vessels. So either one of those would work. So about 50% of subarachnoid hemorrhages are fatal. That's pretty high. 10 to 15% of those people who are experiencing them will die before they even get to a hospital. So it's pretty rapid. Those who survive often do have some kind of neuro or cognitive impairment. So 85% of subarachnoid hemorrhages are caused by an aneurysm. There's also something called an arteriovenous malformation. That's an anomaly, I guess you would say, that can happen at birth, and those things don't show up until there's problems, and then of course there's trauma. So if you hear of someone who says that they've had an AV malformation, they've probably had somewhat of a subarachnoid hemorrhage that led to that diagnosis, or maybe they've had some other problem that they caught this just by chance. Most often people with AV malformations have some symptoms that lead to the diagnostic conclusion. Anyway, treatment for a subarachnoid hemorrhage, if it's an aneurysm, you have clipping, and that's done via craniotomy, so an incision made into the skull, or coiling, and that's done endovascularly, so it's less invasive. They go up through the femoral artery. One of the biggest problems, and something you need to make sure that you keep in mind, is vasospasm. Vasospasm is a huge problem with subarachnoid hemorrhage, and it can cause brain tissue ischemia. So a drug that you should be familiar with for treating these vasospasms is nimodipine, or Nimotop is the brand name. Remember, it ends in a P-I-N-E, so pine, it is a calcium channel blocker. And you want to also control systolic blood pressure. Now, blood pressure typically is not controlled by the nimodipine. That's specifically used just for the vasospasm. So another medication could be used on top of the calcium channel blocker, maybe even a different calcium channel blocker like clevetapine or nicardipine, in order to control that blood pressure. So keeping that blood pressure between 130 to 150 and typically below 130 is really important. So the clipping or even the coiling has time to heal. You do not want extra pressure exerted on the incisions. So there's a couple pictures here of coiling and clipping.